So ulcerative colitis is a condition that can affect so many of our patients in so many different ways, and it can be hard for us as GPs to recognise it and manage it appropriately. So I'm Kevin Barrett, I'm a GP in Hertfordshire. I work with Crohn's and Colitis UK and the Royal College of General Practitioners as part of that Inflammatory Bowel Disease Spotlight project. So NICE have updated the guidance because there's a wide variety of care across the UK. Some areas provide fantastic care with great access to outpatient appointments and inflammatory bowel disease nurses, whereas other areas find it hard to recruit and lots of the care can be left up to the GPs to manage. So ulcerative colitis can be a condition that is managed quite a lot in secondary care. This film is there to help general practitioners interpret that guidance, bring it to life and make it real for us and for our patients. So ulcerative colitis is a condition that affects at least 146,000 people in the UK. It affects the bowel only, generally affects the distal end of the large bowel and affects the lining, the mucosal, rather than being a transmural disease. Genetics do play a part, however there's no evidence that diet or lifestyle play a part in triggering it off. There is some evidence that smokers are slightly less likely to get it than non-smokers. However, the harmful effects of smoking far outweigh any potential protective effects that one might get from it. So it's a condition that can affect people of any age, although it typically affects people in their late teens and early 20s, with a secondary peak later on in people that age in their 50s and 60s, although the evidence is showing that actually those peaks are flattening off as time develops. So ulcerative colitis is a condition that affects the large bowel only. It can affect different sections in different patients. Some patients just get proctitis, some patients it's the rectus sigmoid area that's affected, some patients get left-sided disease that goes up to the splenic flexure, and some patients get a pancolitis that affects all of the large bowel. As well as affecting the bowel, there are extra intestinal effects that can occur with it, so it can affect the joints, liver, eyes and skin. So ulcerative colitis can present in a number of different ways in primary care. It can be very straightforward to diagnose, so patients can present with typical bloody diarrhoea, urgency, weight loss, those are very, very typical obvious symptoms. However, some patients don't always get those and can present just with a gradual change in their bowel habits, not necessarily with blood in their stool. Ulcerative colitis doesn't always affect just the bowel though. There are some patients who present with symptoms affecting their joints, their skin, their eyes and their liver. The symptoms of ulcerative colitis can overlap with those of so many other different conditions as well, from colorectal cancer through to ovarian cancer, endometriosis and a range of other abdominal conditions too. There's an increased risk of bowel cancer in patients with ulcerative colitis. NICE states that a typical patient with ulcerative colitis can have a risk of colorectal cancer of up to 18% 30 years from the date they were diagnosed, which means for patients diagnosed in their 20s and 30s, by the time they're 50 or 60, there's almost a 1 in 6 chance of having colorectal cancer. So the diagnosis of ulcerative colitis has to be done on histology. So it's not something that we can actually make a formal diagnosis of in primary care. We need to think about suspecting it. For the symptoms, the history are really key, really important, as with lots of things in primary care. Examining the patient's abdomen is important, and actually doing a rectal examination can give us a lot of information too. Our role as GPs is to take a good history, examine the patient, exclude red flag symptoms and investigate appropriately. Involving the patient is always important, but particularly so with ulcerative colitis, as these patients are often young. They're either still in education, starting careers, starting families, they have responsibilities that need to be managed as well. And those aspects of their lives are really important in making decisions about their treatment and their ongoing care. And the NICE guidance is very clear that patients should be involved with this, as with all things, but they should be at the centre of their care. Involve them in discussions, talk through the various options, what the treatments are, ensure that they're aware of the screening for colorectal cancer, the risk of osteoporosis, the risk of long-term steroid use, malnutrition, contraception, fertility. These are all key things that our patients should be partners with. So the investigation of ulcerative colitis in primary care involves taking blood tests for full blood count to look for anemia and CRP or ESR to look for inflammation. If those tests are raised, then the suspicion of ulcerative colitis is quite high, whereas if they're normal, then it may be worth considering doing a fecal calprotectin test. Fecal calprotectin is a calcium-binding protein that's released from inflamed cells, and the levels of calprotectin correlate to inflammation within the bowel. If the levels are high, then that indicates there may be something significant going on, and those patients need further investigation. If from our history taking and examination and blood tests we suspect the patient may have ulcerative colitis, our role is to refer them to see a gastroenterologist. The gastroenterologist will then take on the further investigations. The patient will be seen in clinic, they'll be examined again, have a rectal examination, probably have a sigmoidoscopy if there's bloody diarrhoea present. And once they have the sigmoidoscopy and have the histological diagnosis made, then further investigations might occur. NICE is quite clear that all patients should have a colonoscopy after diagnosis to actually explore the full length of their bowel. When assessing a patient who may have ulcerative colitis, one needs to think about red flags. One needs to think about the acutely unwell patient, so patients who actually may need admission because they are at risk of sepsis and acute kidney injury. The Truelove and Witts criteria outlined in the NICE guidance gives a very standardised way of assessing patients who may need further treatment and assessment. One also needs to be aware of patients who may have colorectal cancer, and NICE NG12 gives very clear guidance about those patients should be referred on the 2-week wait pathways. So patients that present with symptoms that could be ulcerative colitis can also have a range of other conditions as well. So they can overlap with irritable bowel syndrome, with infective gastroenteritis, with infective proctitis, with celiac disease, and with ovarian cancer, colorectal cancer, and endometriosis can occasionally give the same range of symptoms as well. So it can be tricky for us sometimes to diagnose in those patients who present with less clear-cut symptoms. The management of ulcerative colitis depends upon the extent of the disease, where it is in the bowel, and the severity of the disease as well. So the mainstay of treatment are rectal preparations and oral preparations. Patients who have very, very distal disease, just affecting the very far end of their bowel, can be treated successfully with suppositories. Patients who have more extensive disease further up may require enemas or liquid preparations. Sometimes a combination of those two is required because of the delivery mechanism. With some actually gets it part the way up the bowel but misses the very end of the bowel as well. Patients with more extensive disease respond better to oral medications as well, and sometimes a combination of oral and topical therapy is required. Some patients do require steroid medication as well, and again these can be delivered locally or orally. Oral steroids again are useful for getting disease under control, but the long-term effects of long-term steroid therapy can be harmful with osteoporosis amongst other things, and generally it's better to avoid long-term steroid therapy unless other options have been explored. So patients given mesalazine treatment can take a little bit longer to respond to those than those given steroid treatments. Generally it's a good idea to assess response to treatment within 2 weeks, and if a patient is no better, then to escalate it to the next level. Clearly if a patient deteriorates during that time, then other measures need to be taken and advice needs to be sought from a gastroenterologist or the IBD advice line. So once a patient's symptoms are controlled, it is important for them to continue on long-term maintenance therapy of their medication, as this does reduce the chance of recurrence and also reduce the chance of colorectal cancer developing in later life. Some patients with acute severe ulcerative colitis require surgery, particularly patients who present with very severe symptoms who don't respond to initial treatment. So NICE provides guidance for hospital practitioners to assess those patients. There are clear criteria in there for when to get the surgeons involved to make that joint decision about surgical option. With ulcerative colitis, it's important that the entire team works together as well. And by the entire team, I don't just mean the hospital team with the gastroenterologists and dietitians and psychologists. I actually mean involving primary care within it as well. Liaison between primary and secondary care is key. Patients come to see us for a whole host of different reasons, and we need to know what's going on in secondary care. And likewise, secondary care needs to know what we're doing in primary care as well. They need to know how many courses of steroids we've prescribed, any new diagnoses that the patients might have that might affect their ulcerative colitis, and also generally what else is going on in patients' lives. The more information we share between the two sides, the better. So once a patient is discharged from secondary care back to the care of the general practitioner, it's important for us to actually make some baseline observations to make sure the patient's weight is stable, that they're taking the medication, because compliance is really important, and also think about the other aspects of their lives, what's going on with their family, with their work, and also to think about bone health, to make sure they're having their regular screening. But there's no set guidance about what general practitioners should do once a patient has been discharged. So ulcerative colitis can affect patients in quite personal ways, in ways that they may not be willing to talk to us, let alone their employers about. It's important for us to think about those sorts of things and ask them and say, are there any adaptations that you might need to your work pattern? So for example, being able to work near a toilet, or have a change in work pattern because of fatigue, working from home might be appropriate as well. Because patients with ulcerative colitis are often diagnosed at a point of their lives where fertility and contraception may be issues for them, they can be worried about this. There's no evidence that patients who have well-controlled disease are at greater risk of adverse pregnancy outcomes than others are. So if a general practitioner hears that the patient is planning to get pregnant and they have ulcerative colitis, it's important that pregnancy is planned. Lots of the medications that patients take for ulcerative colitis are safe to take in pregnancy, with a notable exception of methotrexate. The NICE guidance for ulcerative colitis provides GPs with a tool to help them diagnose, manage, and think about the wider implications of the disease on their patients. I hope people find this video useful. I also hope that demonstrates that NICE guidance are relevant to primary care, that we shouldn't be afraid of it, and it's not a disease that's just purely managed in secondary care.